Welcome to the January 2026 edition of the Urology Journal Club podcast. We're going to kick off with a paper from two important figures in the world of urodynamics, Christopher Chappell from Sheffield and Paul Abrams, probably the father of urodynamics, from Bristol in the UK. And this was a platinum opinion in the European urology. They are commenting on two large randomized controlled trials looking at a comparison between what they call comprehensive clinical assessment versus assessment plus urodynamics. And one was in men and one was in women, and the trials' names are Upstream and Future. They make the point that the bladder is an unreliable witness, as symptoms are not conditions or disease specific, and many patients can be inaccurate observers of their disease. Urodynamics is regarded as essential in contemporary practice before surgical treatment, they claim. But this has been questioned in that urodynamics is not clinically indicated in women with uncomplicated demonstrable stress, and they point to a prior study called the Value Study, which looked at 630 women with stress-predominant urinary incontinence. They were randomized to assessment with or without urodynamics, and they were able to show non-inferiority by simply doing the assessment. And we move on now to the two trials that they're considering here. The first was the Upstream trial, and this randomized 400 men to either clinical assessment or plus urodynamics, and they showed non-inferiority, and this was in the setting of men with low urinary tract dysfunction who were being considered for prostate surgery. So that's an interesting finding, that in this cohort of men there was no real benefit, and it didn't impact on surgery rates if the men had an additional urodynamic studies. The second trial to consider here then is the Future trial, and this was looking at in the setting of women. They had over 1,000 patients, and they concluded that the routine use of urodynamics was neither clinically effective in achieving superior patient outcomes. So I think that our clear message is that we're getting related to population-based use of urodynamics prior to surgery, but the authors here are making the point that its greatest value urodynamics is considering complex patients. So perhaps at a population level it doesn't help, but certainly before you're considering invasive treatment in complex patients, you should consider urodynamics. The next paper is a pediatric urology topic. It's usual for obstructive megaureters to be reimplanted through open or laparoscopic surgery, but more recently there has been the introduction of the possibility of using endoscopic balloon dilatation in these children. And this paper in the Journal of Endourology considered patients over a 10-year period. They had 31 dilated ureters in 28 patients, mean age of 9 months, and they were able to demonstrate endoscopic balloon dilatation being successful in 29 out of 31 ureters, so a very high percentage of 93% success. They make the point that most primary obstructive megaureters do respond spontaneously and don't necessarily need obstruction, but where you've got urodynamic support for declining differential renal function, there is a strong indication to intervene, and balloon dilatation appears to be a very good alternative to open or laparoscopic reimplant. So I think there's an interesting paper, and the paper also, which you can click on below, has a nice description of the technique. The next paper is, for me, quite an interesting one, a research letter in the British Journal. And this is discussing the accuracy of cognitive versus software-guided MRI-targeted biopsy in predicting final grading at prostatectomy. So there was a randomized trial which included patients with prior negative biopsy undergoing MRI targeted biopsy. Surprisingly, found no superiority among cognitive versus in-bore software-guided techniques in detecting prostate cancer. And this prompted the European guidelines to suggest refraining from recommending any one biopsy technique over another. And this kind of is a little bit counterintuitive. You'd have imagined with real-time ultrasound-guided MRI fusion biopsies, you'd get a better hit rate if you used that technique rather than simply a cognitive approach. So this study that they're discussing, they aim to evaluate the cognitive approach, again, of MRI biopsy versus software-guided biopsy to determine what would predict the outcome of the radical prostatectomy specimen. In conclusion, they found that when comparing the final pathology, software-guided and cognitive approaches held no significant difference in predicting Gleason grade at prostatectomy. So clearly we need to probably be re-looking cognitive biopsies as an alternative to the more expensive MRI ultrasound-guided biopsies. The next paper comes from Lancet Oncology, which is reviewed in European Urology. And this paper was a randomized trial comparing local anesthetic transperineal biopsy versus transrectal biopsy. And they were able to show a 6% higher detection rate for transperineal for detecting clinically significant prostate cancer. The expert opinion that they gave for this was that not only are you able to detect more cancers clinically significantly, but obviously you're in line then with the European Association of Urology, which has recommended that people change to transperineal as a strong recommendation because of the significantly lower infection and sepsis rate. However, they do make the point that transperineal biopsy was significantly more bothersome, and patient discomfort is crucial and may result in rejection of further biopsies, such as men on active surveillance, for example. And the transrectal is obviously easier to perform, and there is the additional cost of equipment. So it's worth noting this is in the setting of local anesthetic versus certainly in South Africa, most patients would go to theatre for a fusion transperineal biopsy. The next paper comes from the Journal of Endourology and is the one-year outcome from UK centres delivering minimally invasive BPH surgery using local anaesthetic without sedation in the office setting. And I think this will be of interest to listeners. They used 3 different minimally invasive techniques, that being Resume, Urolift and iTint. For the iTint and Urolift, they used local anaesthetic gel only into the urethra, whereas for the Resume they used additionally a prostatic block. They had 81 procedures performed, mean age of 68, and I think of interest the Qmax pre-op was 10 and post-op went up to 13 across these patients. And they were able to demonstrate that there is a feasibility of using MIST techniques under local anesthetic without sedation can improve symptom scores and uroflow. So this is relatively short-term outcome data, but still attractive to say that we are probably going to be able to make these moves towards minimally invasive techniques in the future. The last paper was of interest, looking at novel obesity and diabetic drugs, what the urologist needs to know, and this paper was a comment in the British Journal. They make the point that 30% of adults in the UK are obese, and the GLP-1 glucagon-like peptide-1 receptor agonists are certainly increasingly being used in our community. And this paper aimed to summarize the key considerations regarding surgery for these patients on these drugs. And I think the biggest take-home here is that one of the methods by which this drug works is to delay gastric emptying and activation of the satiety centers, in other words, the fullness centers to tell you that you've eaten enough, and that's how it leads to weight loss. And this delayed gastric emptying is associated with a 10-fold increase in aspiration, which is something that I didn't know. So are there mitigating strategies to reduce the aspiration risk? Certainly there are, and they recommend the use of prokinetics prior to induction, a head-up position, use of a tracheal tube rather than other methods, nasogastric or orogastric decompression, cricoid pressure. All of these common sense measures are something that we need to be alerting our anesthetic colleagues to if we know that the patient is taking these drugs. So there we are, the end of the January edition. Look forward to speaking again in February.